to the next slide. And I'm pleased to be able to have numerous presenters from across the state, various organizations and hospitals across the state from Ohio, sharing their wisdom and their experience with us as we all are charting these unnavigated waters here. So we'll go to the next slide, please. And while I feel that we are all Zoom experts at this point, I do want to stop and ask attendees that if you are able to attach your registration here with your participant code. If you have joined and have not used your participant code, you can still do so by clicking on pound the participant code that you received and then pound again, and that will be able to have you that we're able to realize who you are. We can go to the next slide. And we are group muting the lines. Telephone users can press *6 to unmute their line if need be. And also on the ribbon on the bottom of your screen on the left-hand side, there is a mute and unmute button. Please we do want this to be interactive. We want to hear from you. Please feel free to utilize the chat box. Type in comments and questions into the chat box there. Thank you. We'll go to the next slide. Some goals for today. We do want to share practicalities of implementing strategies right now. And because guidance doesn't really exist for a lot of what everyone is dealing with, we want to come together and have people discuss what they're doing in these situations in an all teach, all learn atmosphere. Prior to the registration, we were to the webinar starting, we were close to 400 registrants and had several submitted questions from registration. We did prioritize down to 2 topics and scenarios, and have asked our presenters to speak to that today. They are alterations to prenatal care due to the COVID restrictions. And then last week we spoke about the recommendations for breastfeeding with the COVID positive or person under interest there, the PUI mom and her infant. And today we're going to talk about the practical applications of breastfeeding in that scenario. We will provide the resources today that we are covering on our website. Those are updated regularly, and we will also be sending out a follow-up survey. We do want to hear your feedback in order to be able to improve. And lastly, these case scenarios are not OPQC recommendations. They are individual institution responses. With that, we'll go to the next slide, and I'd like to turn this over to my colleague, the OPQC OB faculty lead, Dr. Mike Marcotte. Mike?
Good afternoon, everyone. I just wanted to take a second to review the stage that we're functioning in, and just to recognize and appreciate everybody for all their hard work trying to help moms and babies in our state and in many other states around the country as we face this completely unforeseen, completely unexpected challenge. And I wanted to acknowledge that all of us are under an incredible amount of stress, both in our work and at home, and just really appreciate everyone's efforts. It's an amazing and difficult time for us all, and just wanted to express our gratitude. Our goals today are really to share practicalities of implementing strategies right now, and to discuss what people are doing in situations where it's not clear what's going on. So in terms of the data, this is updated from yesterday. We can see that we're nearing 1 million cases confirmed in the world. The rate of new cases has slowed significantly, but we are seeing about double from what we had last week. The CDC reported yesterday 213,144 cases confirmed in the United States, and that is about almost a little over 3 times the amount that were present last week. again, a lot of that has to do with our testing increasing. And in Ohio, yesterday we saw reported 2,902 cases, and that's up from 867 from last week. In our survey, we found that 84% of participants have not had a case in their maternal or neonatal units, 90% have not had ICU cases, and 93% of centers have not tested any babies for COVID-19. One of our sites did report more than 10 cases of maternal COVID-19 and more than 10 ICU cases and more than 10 babies. But I think what we're seeing is clearly just the beginning of the surge, and that over the next 2 to 4 weeks, we're going to see a lot more cases in maternity centers. Next slide. So we're going to do a poll here, and I'll turn it over to Tracy to run the poll. And we're just going to give a few more seconds for people to answer. We really appreciate everyone participating in these polls. Tracy, are we reaching a good number? Should we report out the answers? So it looks like about 75% of our centers are altering the way they're providing prenatal care, and only 3% or 3 of our respondents said that they have not altered their approach. So next slide. I wanted to take a moment to introduce our first speaker, Amy Burkett, who's a practicing OB-GYN laborist at the Cleveland Clinic and is our current ACOG Ohio chair. She's going to share a little bit about what ACOG has guided us in as we modify our prenatal care, and also talk a little bit about what's happening in the Cleveland Clinic system regarding prenatal care visits. Thank you, Amy.
Thanks for giving me the opportunity to speak. I'm excited to see how many people have changed their prenatal care visits, because I think it's a great way to limit risk for our pregnant ladies as well as our physicians. ACOG wholly supports changing the model of prenatal care both now and in the future to allow for the use of telemedicine. We're currently really recommending HIPAA compliant methods whenever possible. There is some ability with the changes in regulations to use non-HIPAA compliant methods. I would check with all of your institutional and legal people before you choose that method. Telehealth is a great option for consults when no exam is needed. There's lots of billing codes, and I provided a link for that. If your patients can get a blood pressure cuff or a Doppler, that's great. That's actually the model that the Cleveland Clinic is trying to use. We were using that model in our telehealth services prior. Those things are becoming limited availability, and so I think that that's may not be an option. If a patient opts to do that for their telehealth visit, it's okay to ask about fetal movement and document that. I think that we are using the American Well platform, but there's a Video Connect and DoxyMe. So I think there's a lot of platforms out there, and choosing which one works within your system and your practice is important. We do support the idea of continued inpatient visits when desired by the patient and the practitioner. Combine the visits as much as possible with ultrasounds, vaccine, glucola, meaning you can slightly adjust the timing of those things if needed, and then do a COVID screen, obviously, prior to arrival, which I think someone's going to address a little further. You can go to the next slide, please. So a little case study here. Obviously, at prenatal visits, patients are very nervous about COVID, and a lot of my partners and friends are telling me that they're getting asked a lot of questions about COVID-19, what it means for pregnancy, how it will affect a developing baby. The data is ongoing in the collection on that. We also get asked about whether they should really strongly consider home birth. ACOG does not support home birth in this situation, or really any situation. Hospitals and accredited birth centers are still the safest place to deliver. We are in a pandemic where EMS and first responders are stressed. OBGYNs are stressed, and it may be harder for those services to get to a patient or their baby if the baby is born at home should an emergency arise. We jokingly say, you know, low risk is a retrospective diagnosis. And what that means is that hemorrhage and other things are unpredictable. And so even if someone's had babies before without complications, we assume that they're going to have an uncomplicated delivery, but we don't know that till the delivery is done. I'm sure all of you have friends who have had a vaginal delivery and had a complication in their next pregnancy and needed a C-section. So lots of compassion, lots of allaying fears of how your hospital is screening patients, what you're doing to reduce the risk of in-hospital transmission, and what you're going to do for the patient in terms of support. So allowing the use of FaceTime and those kinds of things. Now you can go to the next slide. And then here's a great example of postpartum care and telehealth visits. This is one example. Obviously, this can be modified to meet the needs of the practitioner and their patients. Telephone calls are acceptable, using the nurse to call and say at that 1 week visit, how are you doing, what your blood pressure is doing. Again, trying to get them a blood pressure cuff to go home with. I think those things are all great options. This particular one uses MFM to titrate your meds, but you could use the doctor that's answering phone calls that day or the doctor that's on call for the group. Ohio has a great immediate postpartum LARC program, so the insertion of IUD at time of delivery to delay a need for a visit for that is also a great idea. But I think that anything that, you know, gives the patient a chance to connect with their provider, be screened for depression and anxiety, which is a big deal, have their incision checked, but in those kinds of things, but doesn't have to come in the office, is always a great method now, and hopefully as people set up telehealth, be used in the future. And I think unless there are, I think I can take some questions.
Thank you, Dr. Burkett. That was very helpful. We can go to the next slide, and Dr. Burkett has gone ahead and had some of wonderful ACOG resources here as well that are very helpful. Looking through that yesterday, I felt that especially the prenatal frequently asked questions, the second bullet point there was very helpful. I see some comments in the chat box, and please do feel free to chat in how your site is modifying prenatal care. Someone has added that they've moved their prenatal visits to a different building and have designated 4 providers to be clean providers that will do all the deliveries. Is there anything in place like that you're implementing at the Cleveland Clinic, Dr. Burkett?
The Cleveland Clinic has not gone to the idea of the clean providers. There is some about modifying that, and I have heard around the country people have done that, where they have an inpatient team and an outpatient team. That works great if you're a big practice, right? If you're the Cleveland Clinic and you have, 16 OB providers on each side of town and a laborist pool and a hospitalist pool. If you're my friend in a small practice with 4 docs, you got to do things a little bit differently, because having someone on, covering all that inpatient by themselves, if you end up being busy, can be a problem. So I think each team of docs and midwives need to look at what their need for their patients in their hospital system. I've heard of some groups who are combining. So maybe there's a group of 3 or 4 and another group of 3 or 4, and they decide to pool their resources, particularly at the hospital. So maybe they were competing. So kind of like UH and Metro and the clinic are now working together as a region a small private group could say, hey, let's pool our resources to give each other a break. And so there's only one of us doing deliveries at the hospital with maybe a backup system. So I think there are lots of models that can be used to meet the needs for the patients and the practice and keep everyone physically and mentally healthy.
Thank you. Thank you very much. That's very helpful. Great suggestions. We're continuing to get questions and comments in the chat box. Dr. Burkett, if you wouldn't mind having the ability to answer some of those in the chat box, that would be great as we transition to our next speaker. We can go to the next slide. And if you're not on mute and not speaking, if you could go ahead and just mute your line, that would be great. I'm happy to introduce Dr. Kelly Gibson, who is OBGYN maternal fetal medicine specialist at Metro Health Medical Center in Northeast Ohio. Dr. Gibson, if you could go ahead and share with us what's going on at Metro Health with altering prenatal care.
Great. Thank you for having me speak today. So I wanted to go over a little bit about what we have done for our prenatal care for patients, similar to what Amy was saying. A lot of patients have contacted us with concerns about, whether they have a need to go into quarantine, if they need to come in for their visits, if they're going to be exposed if they come in. And so we've done several things to try and assure them and also assure our staff that it's safe for our staff to come in and be seeing and touching these patients, especially for our ultrasound visits. So some of the things we've done, a couple weeks ago, we moved to only essential visits for all the clinics across the hospital. And for our pregnant patients, many of our visits we deemed to still be essential. So I'll show you on another slide kind of how we divided those visits up. And then the visits that we deemed to be not essential to be seen in person, we changed to either telehealth or video visits. We also made changes to our outpatient clinics. So all patients who are coming in have to fill out a little questionnaire about symptoms, and they also get their temperature scanned. And if they pass that screening, then they can come into the clinic. If they screen positive, then they're referred to, we have a COVID hotline number they can call, and if needed, they can be sent to one of the emergency rooms. We also made a lot of changes to our visitor policies, and this was both for the patients as well as our staff to really limit those who come into the clinic to only the people that absolutely need to be there. So when the patient comes in, she has to come in on her own, unless she's a pregnant minor, then she can bring a guardian with her. And all other family is asked to either wait in the car or wait at home. And if they're coming in for an ultrasound, we're trying to give extra pictures or even allowing them to do a short video with our permission at the end of the scan, where we're trying to show them kind of that cute picture of the baby so they can still share that experience with their family without bringing unnecessary visitors into the clinic. We've also made changes to our staffing to take a lot of the trainees out, so only the nurse or physician that needs to be in the room is there. And then we've also moved to group our care. So again, similar to what Amy had mentioned, we can adjust some of when we might do the glucola or maybe give the Tdap vaccine. We have created a process where patients coming in for their ultrasounds are all getting their vital signs checked. And if there's any labs that are due at the time or around the time of their ultrasound, then those are being drawn in the clinic by the nurse doing the vital signs. That's so when the patient then calls her provider later for a phone visit, her vitals are already in the system. So that way we have them as reference in her chart, and she doesn't have to come back in to get her blood pressure drawn. Same thing for her lab. She doesn't have to go to a different part of the clinic to get her labs drawn. We can do it all in the same place. So she's kind of going to less areas where she might be exposed. If you can go to my next slide. So this is the chart we created for when patients should come into the clinic versus what we can do over the phone. And we have a pretty robust MFM practice here. So we see a lot of patients that we deem to be higher risk. Although I like that idea that low risk is really a retrospective diagnosis, but some patients we know are a little higher risk, so we see them more frequently, and especially in the third trimester when a lot of patients who have risk factors like diabetes or chronic hypertension or lupus who may need more frequent fetal surveillance. We have tried to limit the number of times patients have to come in, but we also are cognizant of the fact that there are risks to some of these chronic medical conditions, and we don't want to miss something going on with the fetus or with the pregnant woman because we haven't brought her into the clinic. And so we've tried to show all our providers as well as our patients know when they need to come in versus when we can do it remotely. If you can go to my next slide. So SMFM as well as ACOG has come out with some guidance in terms of telemedicine, when we can do it and how we can code for it. So last month, CMS and then individual states in terms of Medicaid emergently broadened a lot of the access and ways that we can code for telemedicine. So I think a lot of us were starting to kind of dabble in telemedicine, and now we're kind of all the way full in. And a lot of the rules that they changed have made it much easier for us to do that. So the fact that we can use conferencing software that may not be fully HIPAA compliant, I would encourage you to check with your local institution for their policies on this, but at least from a CMS standpoint, things like FaceTime may be allowed. It can be used for new as well as established patients. They don't have to be in a clinic to do the call. They don't have to live in a rural area or have a certain diagnosis. Really, any visit that can be done remotely should be. And then, when we do our documentation, we have to remember we still have to document just like we would if we were seeing them in the clinic. We have to say why we're seeing them and provide a written report for their medical record. If you can go to my last slide. So I wanted to show just a few of the ways that we've used our EMR. We have Epic for our electronic record, although other systems, I think you could find similar ways to do this. And in Epic, we have over to your left-hand side, you can see there's a dot, called the colored dot system. And what we've adopted system-wide is that the week before, we look at our patients listed on our template, and if they need to come in for a visit, we give them a green dot, so they have a formal follow-up in-clinic visit. But if they can be done via phone or video visit, we give them a different color, so a yellow or a white dot. And then our secretaries can go in and make those changes and notify the patient. Your visit is still going to happen. You're still going to be able to contact your doctor or midwife, but phone. So we've converted your visit. So that way we're really doing this ahead of time to let patients know about the changes. You can go to the next. So we made changes to our smart sets and order sets to make our labs all standing or future orders. That way when we do a video visit with a patient, because she's probably not going to the lab that same day, she's probably going to get her labs done when she comes for her next ultrasound, we can still place all the orders in that visit. And then those orders are just pending in the chart for the nurse to be able to give them when the patient comes in for that visit. If you go to the next. So in our documentation, Epic has things called smart phrases, which are basically just preset templates that we can use in our notes. And we created one to say that we have converted a visit to a phone visit because of COVID. And so that's kind of the standard charting that we need to do to talk about time, because a lot of this is time-based billing. And then my last is just we've created, we're using the standard codes for televisits. So they're time-based, so 5 to 10, 11 to 20, and then 21 and over. And we've also used specific modifiers to show that this was used as a phone visit and that it was converted because of COVID. So then later on, we can go back and track the number of visits that were changed over and track the impact on our system from COVID. So these are some of the tools that we've used in our system. Hopefully some of them you can adapt for your system or have been using in terms of changes for prenatal care. If we have any time now, I think I can take a question, or else I can just answer in the chat box.
Dr. Gibson, thank you so much. This is very helpful, very structured process at Metro Health, and we appreciate you sharing it with us. There are some questions in the chat box, if you wouldn't mind answering. Most are specific to the visitor restrictions, and wondered if you, along with Dr. Burkett, could provide some guidance there. What we'll plan to do now is to move forward to the next speaker, and Linda Hoffman is the Director of Maternity Services at Licking Memorial Hospital. I asked Linda to be on today. We received many questions on registration specific to the rural aspect. How are rural communities and rural hospitals responding to the COVID virus with their pregnant patients? And Linda is going to speak to us as to what they've implemented at Licking Memorial Hospital. Linda?
Yes, good afternoon, everyone, and thank you, Susan, for this opportunity. I would think, if I had to sum it up for rural community hospitals, collaboration and flexibility are probably the two words that I would say are key to getting things done, especially in this time. Not only with regional hospitals, because it's important to always have a partner when we need to transfer patients out, but also just working within the hospital itself. You know, as you know, probably in your hospitals too, the maternity center tends to sometimes be a little bit its own little hospital in a hospital. So in these times, it's wonderful to be able to branch out and really use a lot of resources. We've worked very hard with our OB provider's office, the ED, the OR, Med-Surg, just kind of collaborating together for flexibility and looking at how we will move through all of this. One of the things you see up on the screen today, we have an algorithm, and actually there's a lot more to this algorithm. We have actually two, one for the outpatient assessment and management, and then also we have one for the inpatient flow as well, which I can make available to you if folks are interested in it. This was a collaborative effort, very strong collaboration on our chief OB, Dr. Lauren Baker, and our manager in the department, Sarah Fulton, and I just kind of going through and pulling the information together. You'll see that with our OB practice, the first thing that we're doing with all of the patients are phone screened. When they call in for an appointment, when we call them for appointment reminders, anytime there's that conversation, we're doing that screening process. And then from there, the patient is kind of flowed based on her responses to the screening. Then once she comes to the office again, there's the in-person screening. And we've also moved around the offices, the exam rooms, to making one that's a little bit more of for the sicker patients. So that's just the logistics with that. Licking Memorial Hospital is an independent community hospital, and we are the only hospital in our county. So in our service, our maternity services is a level 2 for maternity and special care. So with working with all of within our department anyway, sometimes it's interesting when we get in this surge, thinking about our staffing coverage and how we're going to do that. So it's important, we all sat together, the directors, and we looked at our staff. We did have to do some redeployment of our OR staff due to eliminating the elective surgeries. So we were able to just kind of sit and look and see where we can shift and move some staff who maybe have worked in the emergency room department before or worked in OB. So that was a really critical point for us to be able to look at our staff on the front end and then get those folks in and have them doing a little cross training up front as well. I think that that's always very key to be able to, your staff is your front line, as you know, and we have to be flexible with that. We talked a little bit earlier about having like that clean provider. We're looking at the same thing with our staff and kind of having every day we assign an ER OB triage nurse. And so we're kind of trying to divide that out a little bit too. And I would be happy to take any questions that anybody has.
Thank you, Linda. That was wonderful. I know from working with all the maternity hospitals with OPQC amongst the state in Ohio that there are challenges specific to being rural and there are great benefits as well. So appreciate your guidance here as to how you're doing it in Licking Memorial. And if you wouldn't mind answering some of the replying to some of the questions in the chat box, that would be great. Thank you so much.
Thank you very much.
Sure. Let's move on to the next slide. And in the spirit of I'll teach, I'll learn collaboration, which I think is really a huge cornerstone of the Perinatal Quality Collaborative, we have received feedback from other institutions as to how they are modifying their in-person prenatal care. University Hospitals, as of March 25th, has posted their guidelines for prenatal care, and University of Cincinnati, UC Health also has wonderful FAQ posted that goes to their pregnant patients, that has guidance. This is just a snippet of the portion that's specific to prenatal appointments. It covers all of the components of the pregnancy and labor and delivery. We also will be posting that to our OPQC website, and you can see again that there's a consistent theme here of trying to decrease exposure to staff, to patients, decreasing and eliminating visitors, but continuing, as Dr. Burkett had suggested, Dr. Gibson suggested, the importance of continuing with prenatal care throughout this pandemic. We'll transition now to go to the next slide. And I'd like to go ahead and transition from obstetrical practice to neonatal and pediatric care. That portion of our call now will start off with a poll on breastfeeding. For those of you that were able to attend our webinar last week, we did talk about the changes to recommendations for breastfeeding if mom is COVID positive or PUI. What we'd like to know now regarding your lactation consultations on the postpartum floor and the NICU. Are the consultants fully available in your hospital? Available at a reduced number within the hospital? Available but only through telehealth or on the telephone, or you're no longer having them work with the patients right now, or uncertain? So if everybody who is able to answer this question at their site, again, the lactation consultants, your postpartum and your NICU floors. And Tracy, I'll let you know, I'll turn it to you to let us know when we have a good amount of responses. Okay, so it looks like the majority are fully available in the hospital, 11% at a reduced rate. And interesting that we were focusing so much on the telehealth with the obstetrical presentations, that 7% are using telehealth, and then no longer available. So again, if you'd like to chat in any comments about what's occurring at your site with your lactation consultants, that would be really helpful. We'll go to the next slide. And this, hot off the press here, came out yesterday from the American Academy of Pediatrics. You're able to download it from their site. It's an 18-page document on management of infants born to mothers with COVID-19. I took just the highlights as to what we're discussing today, which is rooming in for mothers and well newborns. Again, this is for moms that are positive, and along the same lines as the CDC guidelines, they are recommending separation of the mom and infant. And then should the mom not elect to do that, they also have the guideline to make certain that there's a 6-foot distance between mom and baby. They also have breastfeeding guidelines, and again are discussing the preference to express breast milk after appropriate breast and hand hygiene. And those who do want to feed breast milk, we are recommending, I should say the AAP is recommending that a caregiver other than mom feed that. Those that do request direct breastfeeding here, again, to adhere to strict preventative precautions. What I'd like to do now is to turn it over to, we have two experts here on breastfeeding. Dr. Jenny McAllister is the medical director of the University of Cincinnati Newborn Nursery and a lactation consultant herself. And we can go to the next slide and turn this over to Dr. McAllister.
Thank you. So I'm going to focus kind of my portion, not necessarily on the decision to separate mom and baby, but more on the breastfeeding decisions around that. And so, as alluded to, mothers should be encouraged to provide breast milk, but I think there's so much variation across not only the world, but across institutions. And we discussed the CDC and the AAP recommendations for separation, but breastfeeding, we feel, should be a shared decision-making with both the family and the healthcare team, depending on mom's status, baby status, and her specific situations. So if temporary separation is occurring, we encourage moms to express breast milk. With that, a dedicated breast pump should be provided, and as discussed, a healthy caregiver should be feeding that expressed breast milk to the infant. If mom elects to room in, she again should use a face mask, proper PPE, washing her breast, and really stringent hand hygiene before feeding. Next slide. And so I wanted to kind of bring up a practical case study here. This is a made-up scenario, but taken from some questions that we've had in the area. So this is a full-term mother, or mother who is at full term, comes into your hospital in labor, and she has just moved here from New York City to be closer to her family. For the last few days, she's had cough and low-grade fevers. And per your policy, you admit her to the negative pressure room, concerning for COVID, place her in droplet precautions, and swab her for the test. Currently, as is in some of our institutions, our testing is sent out, so we won't be able to have rapid results. She goes on to progress and deliver a vigorous baby who is otherwise asymptomatic, and mother was planning on breastfeeding. Next slide, please. So per your hospital's policy, would you allow direct breastfeeding? Is there a role for shared decision-making? And again, you know, I refer you back to your own institutional policies, but this is something that's going to come up, and the idea of shared decision-making is probably something that we all need to be discussing. The risks for not allowing direct breastfeeding have been proposed, including decreased bonding, becoming pump dependent. So if you're not able to establish that latch within those first few days, some babies really do have difficulty going back to the breast and latching directly, especially, you know, when they're using bottles that are free or flowing. There is a concern for compromise to milk supply if they are pumping, or if they don't get pumping established quickly. But the benefits for not direct breastfeeding, as the CDC and AAP have pointed out, is that there's a decreased risk of transmission of COVID to the baby. And although we don't have a lot of data in children, the studies out of China showed that children are less affected, but the highest risk of morbidity is in children under a year. So just taking that into consideration. And then the other question we need to kind of talk about is, what would you do to help mother protect her supply if she is exclusively pumping? Next slide. So this is a little infographic that UC Davis in California had put out, and I kind of snipped it basically just to focus on the nutrition aspect and about shared decision-making with parents. So on the left-hand side in the pink is the kind of more conservative approach to this. And so these would be families who choose that they don't want to breastfeed, or that they would like to breastfeed eventually, but they want to wait till mother is asymptomatic or has cleared her infection. And so your choices would be formula or donor milk if that is your hospital policy and available, or mom could pump and discard her milk until she has cleared the illness. Again, that's probably the more conservative approach. In California, I'm not sure if their testing availability is different than ours in Ohio, and even within regions of Ohio, but the more conservative approach to clear mom of infection would be 2 negative testing, and then testing negative for baby at 24 and 48 hours. Kind of the more middle ground, which I think many institutions are kind of leaning towards, is that moms would be recommended to express breast milk, and then, as we discussed, cleaning appropriately, proper hygiene, and then fed by a healthy caretaker. And then the more liberal approach would be moms who want to direct breastfeed, again, with those same precautions that we've previously discussed. This slide does highlight testing for baby. For those of you who are not familiar with that, all babies that are born to moms who are PUIs, or more specifically COVID positive moms, should have testing 24 hours after birth. This is the AP recommendation as well. And so that would be a nasopharyngeal and oropharyngeal swab and a rectal swab. So they usually get 3 swabs and that is sent off. Obviously, if baby's sick, we would want a tracheal aspirate as well. Next slide, please. And so moving on to discharge, who would you recommend to care for the baby at home? And this kind of depends on mom's status as well, but these are questions we need to kind of think about. And if it is a parent, what type of precautions would you advise the parents using when they're caring for the baby at home and for how long? And then kind of the next step for all of those who are doing lactation and thinking about these more long-term consequences, if you had recommended expressing milk, when would you allow her to direct breastfeed? Next slide. And so again, this is kind of from that same infographic from UC Davis, recommending discharge process, the conservative approach in the pink on the left, and then middle ground and more liberal. And so some of this has to do with mom's testing too, which we may or may not have at the time of discharge, again, depending on your turnaround time for tests. So assuming that mother's positive or a PUI and baby's NAIC test is negative, the conservative approach would be to discharge to a healthy caretaker until mom has had resolution of her symptoms, and again, depending on testing availability, to negative tests. I know there's a lot of questions about who is considered a healthy caretaker and is father a PUI. I think this is still a little bit of that gray zone, and it really depends on mom's support system. I think ideally if father is truly a PUI and he has symptoms, he would not be considered healthy caretaker. But if he's asymptomatic, that is something to consider, again, with appropriate precautions. And so the middle ground talks about mom who is a PUI or positive with appropriate contact and droplet precautions until her symptoms have resolved or to negative tests. On the far right side, if both mom and baby actually are positive, you don't have to separate. You don't have to have mom pump, because at that point, baby's already positive and you can kind of just do care as normal. For those of us who don't have testing readily available, especially with quick turnaround times, the CDC did put guidelines for discontinuation of isolation procedures, which would include discontinuation of PPE. And that would be 3 days after recovery of symptoms. So that's fever-free without using fever-reducing medications and without symptoms of cough or other respiratory symptoms, and at least 7 days since her symptoms first appeared, or since the caregiver's symptoms first appeared. So again, I don't think this is clearly black and white. You have to think about your own institution, availability of caretakers for mom and baby, but these are some of the guidelines for more of a shared decision-making approach. And so with that, next slide, please. Okay, I did have some resource slides that I don't think made it on here that I can share with Susan to send out as well. Those resource slides were basically about how we can help establish milk supply quickly, kind of relating it to the NICU preterm population and how we do early pumping and hand expression for anytime moms and babies are separated. So I can share that.
Thank you, Dr. McAllister. That's very helpful. As you can see, there are a number of questions in the chat box that if you wouldn't mind answering, I think that would be great. The takeaway here certainly is shared decision-making with the family is necessary, and I think everyone is in agreement with that. During these difficult times, the importance of including the family and the parent voice there. The slides you did have, Dr. McAllister, we will include in the deck that we do send out to everybody with those resources. Very helpful. So thank you. I'm going to transition now over to Liz Mazeth, who is with the Maternal Fetal Medicine Center at Akron Children's Hospital, and also, like Dr. McAllister, lactation specialist. So Liz, if you could go ahead and walk us through this case study and some of the considerations for lactation support and breast milk in the NICU.
Why, thank you, Susan, and thank you for the opportunity to share some of the work that we're doing at Akron Children's NICU and Maternal Fetal Medicine. I wanted to let you know this particular case study had occurred actually over the weekend. So this is fairly new and a new process. So this particular baby and mom and dad, this is a now 5-month-old, a former 27-weeker who has multiple respiratory and GI issues. I had reached out to mom because she was not seen in our usual fashion. Usually we try to see our moms once a week, so I just did a follow-up call. And mom had shared with me that dad was under investigation for potential exposure, community exposure, and was tested, and we were waiting for final results. This mom had no idea on what she needed to do in the NICU and everything that goes along with breast milk storage guidelines and so forth in mothers and dads and families who are experiencing this. This particular mom and dad were quarantined until those test results had returned. And so what I did and how I supported this mom over the telephone was in this particular way. I instructed mom on the use of excellent hygiene with hand washing, washing of the pump that she's using with a type of wipe if she has that available to her at home, making sure that her pump kit is both washed with hot soapy water, rinse it very well, let it air dry, and then for her to go ahead, because again, we don't know if mom is under investigation, that we also are having her breast milk storage containers also cleansed with a wipe of some type that mom has at home. I just had read an article actually that showed us that the COVID-19 virus can live on plastic for 72 hours. That was under a New England Journal of Medicine article. I also encourage mom that she pump again those 8 to 10 times a day. But one of the things she was not doing, we found out, is that she was not pumping, or not taking her temperature daily. So I did encourage her that she do that to see if she was going to wind up with any type of symptoms. We also had an issue where now with the Center for Disease Control that the use of the sanitization bags is also encouraged. And so this mom did not have those at home. So I encouraged her to either have family, friends, neighbors who would be able to go ahead and obtain those bags at Target or Walmart, and then to provide those for her so that she would be able to sanitize her pump kit once daily. And then I just reviewed the signs and symptoms of COVID-19 so that she would understand, you know, what we were looking for. Next slide, please. So our approach for practical application in lactation support within the antepartum setting. So my maternal fetal medicine specialist and my nurse practitioners will have an order that would be placed in the mom's chart for me to go ahead and follow up with them. We are now, because of the Society of Maternal Fetal Medicine Specialists, are now encouraging telehealth only. And so we are no longer using the PPE. We were able to provide one-on-one, observation and or discussion, but now I'm doing a telehealth breastfeeding classes, antepartum assessments, and antepartum education for our moms, especially in potential NICU with our fetal treatment center and within our maternal fetal medicine practice. And then the other thing that we also do is that we have an open discussion with our moms specifically regarding COVID-19, because even though they are apprehensive about it, just gently opening up that discussion actually has helped mothers to understand why the use of human milk and breastfeeding is so important. In the postpartum portion of this, moms are now given the opportunity, if they want a one-on-one visit with the PPE, with the lactation consultant, or they can do a telephone consult as well. And the other thing, next slide, please, that we are doing specifically to support our moms in the use of human milk within our NICU is that how we were able to store breast milk and how it was going to be able to get from mom who was COVID positive or a person under investigation and so forth. So I had the opportunity with Dr. Jennifer Groh, who is our director of our neonatal intensive care services there at Akron Children's, and found out, because her concern was, how are we going to be able to do all of this? I had the opportunity actually to speak to my colleagues at Seattle Children's as well as through the University of Washington. And we were able to come up with some ideas that we were able to do this. And here's what we did for the following and what their suggestions were, and perhaps some of the things that we're going to be doing as well. If a mom has a positive COVID-19 test, or she's a person under investigation, again, following the very same things, such as excellent hand washing, cleaning her pump with some type of a wipe. They don't have, of course, maybe a bleach wipe or something like that, and washing the outside of her pump breast milk storage containers. The next thing is that now, how do we get that transported? At Akron Children's NICU, we don't have the opportunity by which that we have refrigeration inside of our NICU. We actually have a milk lab. So again, working through that process and have come up with some ideas. At Seattle Children's and University of Washington, they do have breast milk storage available to them, and they have the use of wiping the external or the outside of the container, placing that into a plastic bag, and placing that into the refrigerator. We at Children's are doing something a little bit different, and we have that one case that I had spoken to you about. I do know that we do have another mom who is separated from her baby with a baby over at our Suma NICU as well. And then the transportation, especially for mom at home. So again, reviewing good hand washing, washing her pump, making sure she's washing her pump parts, making sure that we're sanitizing her kit once a day, and then the meeting the mom at the an area where the milk would be able to be dropped off, and either the lactation consultant and or nurse and or secretary, someone would be able to go ahead and pick up that milk. And then the other option I wanted to, in order to provide for you here, and that was regarding unit policies and kangaroo care, specifically looking if a mom is COVID-19 positive or a person under investigation, the use of kangaroo care should not be done in this particular case. And then one more point, if I may, and that was I had reached out to the Ohio Health Mothers Milk Bank looking specifically for guidelines, and I believe that Susan is going to be able to place that in an extra slide on this about what mom would do if she desires to donate milk to the Ohio Health Mothers Milk Bank. And with that, any questions? Does anyone have any questions?
Thank you, Liz. That was very helpful. Questions for Liz, please feel free to chat into the chat box and she will answer them as best as possible. And we will get that link from you regarding the human milk bank and post that on our website as well. That would be very helpful.
Excellent. Thank you.
That's great. Thank you. Let's go to the next slide. And Dr. Heather Kaplan, who is one of the NEO faculty for OPQC, is going to share some opportunities for parent handouts and then also for a registry to participate in. Heather?
Thanks. Yep, thanks, Susan. So I just wanted to bring this to everyone's attention. It is going to be posted on the OPQC website. This was a resource that was put together by Paula Meyer and Aloka Patel from Chicago, both breastfeeding researchers and practitioners extraordinaire. And this is an information sheet regarding the provision of breast milk for by moms who have either COVID-19 or have been exposed. And they've done a great job with this, specifically directed for families, and it's available in Spanish and English, so that we will make that available for you guys. They want it to be shared widely, so it's going to be available for you to use with your patients and families, specifically directed to the NICU. But again, the section at the bottom related to some of the hygiene related pieces, it would be helpful regardless. Next slide. And then I just wanted to bring to everyone's attention 2 opportunities that exist for participating in COVID-19 neonatal registries to start to collect data on the pandemic as it emerges in the US and affects our patients and moms. So there's one opportunity through the Vermont-Oxford Network, also associated with the AAP, that's going to be a monthly audit. So it's going to start this month in April, and you just choose a day of the week that you want to audit. And it's pretty simple questions. It's probably only about 15 minutes worth of time, tracking mostly numbers of patients that are positive, exposed, et cetera, as well as some of the resource challenges that units are facing. The cool thing is that you can track your unit's data over time as you audit from month to month, and then we can look at our data as an aggregate in Ohio as well. So if you're a Vaughan member hospital, you should have received information about this by email. If you haven't, then go ahead and reach out to your Vaughan site administrator in Burlington to get hooked up with that. The other opportunity is a much more in-depth registry that's being sponsored by the AAP section on neonatal perinatal medicine. It's been approved by the University of Florida IRB, and it's collecting quite a bit of de-identified information, but no PHI or personal health information. But they're looking at, right now, only data from mom-infant dyads where mom has confirmed COVID-19, and there's some definitional restrictions there. So that one is going to be a treasure trove of information to help us, and they're going to publish it in an ongoing way so that we can learn from it. And so if you're interested, there's more information at that website that's listed there, including what you would need to do to sign up, and then a link to sign up to participate there as well. Next slide.
And this is Mike Marcotte.
Yep, there you go.
Yep. I just wanted to make everybody also aware that the University of San Francisco has started a registry called the Priority Study, which is also for moms that are COVID-19 positive and or are under investigation. And likelihood is that this is going to be combined with an NIH registry when that gets up and running. But for right now, if you have any patients, we do encourage you to include them in the enrollment here. And more to come. We'll keep you guys updated as we learn more about the NIH registry.
Thank you, Dr. Marcotte. Let's go to the next slide. So clearly, just with the feedback and the robust interaction amongst the group chat, we really feel that coming together and discussing what we're all seeing, what we're all learning has been very helpful. In this vein, we're going to continue these webinars. OPQC currently has a maternal opiate medical support plus is for plus baby. That is a quality improvement project working with a number of sites in the state of Ohio. We are going to have a Moms Plus specific call next Tuesday. We're planning to address care for women with opioid use disorder during pregnancy specific to this pandemic. It is open to everyone, whether you're in Ohio or not, whether you're participating in the Moms Plus project or not. And again, that is care of the pregnant woman with OUD, care for her during this pandemic. Next week, I think even today, some of the talk was about planning for surge and what we're looking forward planning there. And we will be having on Friday, April 10th, surge planning for both OB and neonatal units. We hope you will join us for that. If you have a plan in place that your site is working on, please feel free to reach out to us if you'd like to share it with us. Or perhaps if you'd like to present on that call. We are in the process of working with leaders across the state of Ohio to share on that call, and would be very interested in sites plans specific to surge planning. On the next slide, we have included the contact information for today's presenters, and I can't thank each of them enough for taking time out of what I know is an incredibly busy schedule, as are all our attendees, to participate today, to all teach, all learn. I'm very, very grateful and appreciative for everyone's time and effort today. If we go to the next slide, our website will be having an update of the resources that were shared and discussed today. And we will go ahead and also have a link to the webinar slides and to the recording as well. And we'll go to the next slide. And again, just thank you so much for taking time out of your day to spend it with us, sharing and learning. Do take good care. Goodbye.